To have you in this session, sir, who are present here. To all the participating doctors, Dr. A.K. Virmani, sir, has joined us. Sir is MD, DRM, consultant physician, and cardio-diabetologist at Jamshedpur. Sir, we'll be discussing acute chest pain and internist approach today. So, thank you very much, sir, for sparing your valuable time for us. So, if you're ready, you can start the discussion, sir.
Okay, are my slides visible?
Yes, sir, it's clearly visible, sir.
So good evening, friends. Today I'll be talking upon a very important topic, acute chest pain, how an internist should approach. Most of us sit in our clinics or in the emergency department and have patients presenting to us with acute chest pain. How should we assess them, and management is very important in such cases. So that is what I'll be discussing today. Now, acute chest pain is a very common complaint in the emergency department. In fact, 5% of all the ED visits, or 5 million visits per year, have been recorded all over the hospitals. It has a wide range of etiology from cardiac, pulmonary, gastrointestinal, or musculoskeletal. Now, why it is important to distinguish between this cause? Does it really matter? And how do we distinguish the various causes of chest pain? We must remember chest pain that can kill, and missing it can lead to very serious medical legal consequences. Patients presenting with acute coronary syndromes, pulmonary embolism, aortic dissection, esophageal rupture, pneumothorax, and massive pneumonia with septicemia are the conditions in which the patient can die unless properly managed. There are others like pulmonary hypertension, myocarditis, and temporal. But it is very important to remember these six as the initial causes. Now, there are something called benign causes of chest pain, and this is basically musculoskeletal in nature, or simple esophagitis, or bronchitis, chest pain secondary to cough, or in some ladies who place nipple rings, or those hippies who place nipple rings, or so-called non-specific chest pain. And what do we mean by non-specific chest pain? In fact, that's the most common, means we don't know, but at least it is not going to hurt you. So that is also important to diagnose once you have ruled out major causes that can harm the patient. Now, history is one of the most important uh, ingredients of diagnosis in such cases. What is the location of the pain? Is it central, left side of the chest, or right side of the chest? Is it associated with any symptoms like breathlessness, sweating, nausea, or even vomiting? What is the timing of the pain? Is it gradual or it is sudden onset? What provokes the pain? Something on standing or lying down or turning? And what makes it worse? Bending. What is the quality of pain? Does it appear to be visceral, right, coming from inside the body, or is it superficial or somatic in origin? Does it radiate to the back, neck, arm, jaws, etc.? And what is the severity of pain on a scale from 1 to 10? Now, these points must always be taken in the history because they can give you a clue of what the diagnosis is. Once you have taken these clues, these points from the history, then you go for the rest of the history. You ask in the past medical history, any family history of ischemic heart disease, any other history is there. Is the patient on any cardiac medications, whether he's taking nitroglycerin, aspirin, Plavix, or any anticoagulants? Are there any allergies? That's very, very important. Is he a smoker alcoholic? Does he abuse drugs like cocaine? Or there is any family history of sudden death, early MI, deep vein thrombosis, or a pulmonary embolism? And this is the other part of the history. Now, when the patient comes to you, in the first 60 seconds, what you should do? Assess the patient just by looking at him. How does the patient look? What are the vital signs? Pulse, blood pressure, respiratory rate, fever, saturation of oxygen, and perhaps a blood sugar value. These are the vital signs that we consider today. And listen to the story of the emergency doctor, what he has to tell you. And what are the physical examinations that you do, which are very important at this stage? Of course, the general appearance, and I said the vital signs, the pulse, blood pressure, respiratory rate, fever, the partial pressure of oxygen, and today even blood sugar. Examine the heart sounds are muffled, regular, fast, or irregular. Lungs, are the breath sounds equal, or wet, or tympanic? Is the JVP, jugular venous pressure raised? Is the abdomen distended? Is there any edema in the legs or calf tenderness? Now, these are the physical signs that you have to immediately assess within the first 1 or 2 minutes. Once you have assessed this and you know where you stand as far as the diagnosis is concerned, in the next 5 minutes, there are two things that you must do immediately: bedside test, and that is getting an ECG done and a portable chest X ray. So, an X ray and ECG, after having the vital signs, it is very important to do those two tests. And if you have to give a medication at that stage, then the cheapest and the best medication would be giving an aspirin if there is a very strong suspicion of an acute myocardial infarction. Having done this, done the ECG and the X-ray, in the next 10 minutes, patient is already stabilized, initial data gathered, initial orders submitted. Then what do? Then you make a secondary survey. You go for a more detailed history and physical examination. You address the patient's pain. Now the goal is to categorize the pain. Is it a chest wall pain that is musculoskeletal in origin? Is it a pleuritic chest pain that is respiratory in origin? Or is it a visceral chest pain that is cardiac in origin? So let us look at some of the cases. I'm going to give you some clinical cases that often we see in our routine practice. Now, first case, a 46 years old male with a known diabetic, hypertensive, history of coronary artery disease. He had MI 1 year ago and says, I think I'm having an heart attack. And this is the way he presents with his fist on his chest. ECG is, of course, as I said, you've done an ECG. It is specific but not sensitive. It is going to tell you what you have to do now. If an ECG is normal, it does not rule out coronary artery disease. But if there is an ST elevation in two contiguous leads, it is ST elevation MI. And if there is a new LBB or left bundle branch block, again it is ischemic in origin. Or there may be other signs of ischemia and strain like ST depressions, new T wave inversions, and Q waves. Or there may be non-specific signs like T waves, flattening and inversion, or Q waves without an old EKG. You don't have an old ECG. So you don't know whether the Q wave is fresh in origin or it was there earlier. Now let us look at this ECG, a patient who presented. We see ST elevation in lead 2 and lead 3, and then AVF. Now this is, and with reciprocal changes in V1, V2, 3, that means there is T inversions in V1 to V3. So this is a classical case of acute inferior wall myocardial infarction. Now ideally, if the facilities are available, this patient should go to the cath lab from a primary PCI. But if a primary PCI is not available and patient has had chest pain for less than 180 minutes, then consider giving thrombolytic therapy. And nowadays, earlier we used to give streptokinase, but now you can give even reticule. Now, get a chest X-ray done to look for failure and evaluate for other causes of chest pain. Now, cardiac enzymes may at times help you when there are the classical changes of ECG are not seen, and it is the cardiac troponin T which rises very fast, and you can do a troponin T and you will find out. So, what else can we do for this patient? We can give him an aspirin immediately. Great benefit, little risk, at least a minimum of 182 milligram or half a tablet of 360 milligram or 350 milligram of discipline. If the patient still has in pain, give him a vasodilator like nitroglycerin that will reduce the P load. It can be given sublingually at your clinic immediately. Heparin, mild benefit, consider risk. Morphine is now a questionable value and we don't use it any longer. Beta blockers can be given orally. Avoid a patient such symptoms of heart failure, including heart rate less than 110. Then use of the Plavix and 2B3 inhibitors are dependent upon cardiologists, and it's a problem if the patient has to go for a CABG. So it is better to avoid this at the moment. Just give him an aspirin and refer him to a higher center, and if necessary, a sublingual nitroglycerin. Coming to the second case. Now, this is a 30-year-old male who had an open reduction and an implant fixation of ankle fracture 2 weeks ago. He's in the orthopedic ward, and you are asked to see him because he complains of sudden onset of chest pain. Now, this is a classical scenario of an acute pulmonary embolism. So, what are the signs and symptoms of this disease, and what are the risk factors of this disease? If you look at pulmonary embolism, the risk factors are number one, hypercoagulability. And this is often seen in patients with malignancy, in pregnancy, in those who are using estrogens, factor 5 laden, protein CS deficiency, then venous stasis, like bed rest more than 48 hours, recent hospitalization, long distance travel, especially long distance flights, venous injury, recent trauma, or surgery. The diagnosis depends upon the symptoms. There is sudden onset of breathlessness or dyspnea present in 90% of the patients. There is a pleuritic chest pain, 66% of the patients with pulmonary embolism. There may be cough, which is of sudden onset, and even hemoptysis. Signs will reveal a tachycardia of more than 100 beats per minute, an increased respiratory rate, that is tachypnea of more than 20 breaths per minute. The SpO2 will show hypoxia of less than 95% on room air, and there is swelling of the lower extremities. Now, the diagnosis is, as I said, the findings are tachycardia, a right axis deviation, an incomplete RBB, and T wave inversions both in the inferior as well as the anterior leads. But the classical pattern is known as the S1Q3T3 pattern, and this stands for a deep S in lead 1, a narrow Q in lead 3, and an inverted symmetrical T wave in lead 3. So S1Q3T3 is almost diagnostic of pulmonary embolism on ECG. Of course, lab diagnosis, D dimer is very sensitive when there is a low to moderate probability, but it is not sensitive enough for high probability, and it is not specific because a lot of false positive cases are there. Spiral CT is the current gold standard. It is available, freely available now, but caution has to be used when you are using the contrast, and you must look at the creatinine clearance. Now, ventilation perfusion studies will show indeterminate and are not freely available. every day. Venous Doppler ultrasound of the lower extremities. It shows the presence of a clot, even asymptomatic, in the proximal lower limb veins of a patient with clinically suspected pulmonary embolism, provides enough evidence of venous thromboembolism and indicates anticoagulant therapy in such patients. So you can get a positive compression ultrasonography of the lower limb veins. The treatment of pulmonary embolism, you must give IV fluid to maintain blood pressure. Heparin, that is the low molecular weight heparin or maybe heparin directly, will limit propagation but does not dissolve the clot. You can give unfractionated 80 units per kg bolus and 18 units per kg per hour, or fractionated 1 milligram per kg subcutaneously twice daily. Fibrinolytics can be considered if the patient is unstable and the thrombosis is large. However, no study has shown survival benefit with fibrinolytics, but it's very difficult to study. And altiplase has been used 50 to 100 milligram infused over 2 to 6 hours. Let's come to the case scenario 3. This is a 35-year-old male with sudden ripping pain radiating to the back. Any pain radiating to the back, think of aortic dissection. Now, what is aortic dissection? If you look at the aorta, we have an outer layer, a middle layer, and an inner layer. When there's a tear in the intimal layer or the inner layer, and the blood oozes in between the middle layer and the inner layer, it is known as aortic dissection. That is, blood violates the aortic, intimal, and adventitial layers, and there is a false lumen. There is a false lumen that is created, and dissection may extend either proximally, distally, or in both directions. Now, it has got a bimodal distribution. In the young, it may be seen in association with connective tissue disorders like the Marfan syndrome or even in pregnancy. In the elderly people, most commonly over the age of 50 years, mean age being around 63 years. The risk factors are gender, male, 66% patients are males, 72% are hypertensive, then 30% may have connective tissue disease like Marfan's patients get dissections, or even drug abuse with cocaine and syphilis, which is now very rare. Now, what are the clinical features of a aortic dissection? It is a very difficult diagnosis, but you have to have a very high index of suspicion. 85% of them will have chest pain that is radiating to the back, or even only upper back pain. It may be ripping or tearing in 50%, and 20% there will be neurological symptoms like numbness of the hands. There will be hematuria, and there are asymmetrical pulses if you examine both the radial pulses. The diagnosis, if you do a chest X-ray, you're going to find a widened mediastinum, an abnormal aortic knob, and pleural effusions. But it is not very sensitive since 25% of patients themselves per se may have a wide mediastinum. Chest CT is very sensitive and specific, quickly obtained, but must think about kidney plus contrast. Angiography is the gold standard, and you can reliably see the anatomy of dissection, and a bedside ultrasound can be done to evaluate aorta and look at the heart to rule out tempora. Now, this is what happens. The DBT classified into stage 1, where you have involvement of the arch of the ascending aorta and the arch of aorta, and then in 2 with only the ascending aorta, and 3 where it is the descending aorta. So this is the classification, but basically it is a difficult disease to diagnose, and one should have a very high index of suspicion. How do we manage this patient? It is very important to involve the cardiothoracic surgeon because these patients require surgery at the earliest. One must, at our level, we have to see that the blood pressure is maintained properly. The systolic goal should be around 120 to 130 millimeters of mercury, and beta blockers, especially labetalol and esmolol, are the first drugs of choice, and we can add vasodilators like nitroprusside to get the blood pressure under control. Obviously, the patient needs to be admitted in a critical care unit and needs surgery. And if the only descending aorta is involved, then patient is likely to improve with medical therapy. Let's go to the next case. A 50 years, 55 years alcoholic with persistent vomiting after a binge of drinking presents with sudden onset of chest pain followed by hematemesis. He has massive hematemesis. Now, what is this disease and what are the risk factors for this disease? This is known as Boerhaave syndrome or spontaneous esophageal rupture. Now, if you look at the X-ray, you can see air because of the esophageal rupture on the cardiac border, and you can see even subcutaneous emphysema. And this is again air in the cardiac border because of the rupture of esophagus. So, because the esophagus lacks a serosal layer, it is more vulnerable to rupture or perforation. Once a perforation, that is full thickness tear in the wall occurs, the retained gastric contents, saliva, bile, and other substances may enter the mediastinum, leading to mediastinitis. And within a few hours, there is a polymicrobial bacterial invasion, leading to sepsis and eventually death if patient is not treated either surgically or with proper conservative management. The mediastinal pleura often ruptures and gastric fluid is drawn into the pleural space by the negative intrathoracic pressure. And then the perforations are usually longitudinal, with the left side more commonly affected than the right, almost in 90% of the cases. So the combination of a subcutaneous emphysema, rapid respirations, abdominal rigidity is referred to as the Anderson triad and is classical of Boerhaave syndrome. Now, CT esophageography can give you the best result, and it is almost diagnostic. Never go for a gastroduodenoscopy because of the acute esophageal rupture. It can deteriorate the condition further. So CT esophagography is the diagnostic strategy of choice. Let's look at the other case. An 18 years healthy male was lifting weights when he had sudden onset of sharp chest pain and breathlessness, tachycardia, high respiratory rate, low systolic blood pressure, a low saturation of 88%, and on clinical examination, the breath sounds on the left side of the chest were decreased. So what do you do first? What do you think this is? This is a tension pneumothorax, and this is what is happening. This is the normal lung on this side, and on the right side and the left side we see air compressing the lung. The black portion is the air. So what we need to do is we need to put in a needle immediately in the second intercostal space to decompress it, just above the third rib. And that is the ideal place to place the needle, and then the air will go out and patient will be relieved immediately. Once you have done that, you can call the surgeon to place in a chest tube till the lung expands fully in maybe 2 to 3 days, and then gradually the chest tube can be withdrawn. The last case, pneumonia with pleurisy. If you see this is a normal lung, and here you can see a pleurisy or inflammation. There is redness of the pleura. There is thickened and inflamed pleura. The layers rub against each other, and what you hear is a pleural rub. So this pleurisy or pleuritis is inflammation of the membranes that surround the lungs and line the chest cavity or pleura. So patient has a sharp chest pain, shortness of breath, cough, fever, or weight loss depending on the underlying causes. Of course, tuberculosis is still one of the commonest causes, but even viral infection is very important. Then we can have other causes include pneumonia, pulmonary embolism, autoimmune disorders, lung malignancy, or following heart surgery, hepatitis, trauma, and even asbestosis. Sometimes it remains idiopathic. The underlying mechanism involves, as I said, the rubbing together of the pleura instead of smooth gliding. Of course, we have to differentiate it from a pericarditis, acute MI, cholecystitis, and pneumothorax. Let's start. Okay. You do a chest X-ray, ECG, and the routine blood test to rule out high PLC, and treatment depends on the underlying cause. And just to relieve pain, you can give either paracetamol or an ibuprofen tablet. Then later on, incentive spirometry is recommended to encourage the expansion of the lung to its normal levels. So if you look at the algorithm of chest pain, the patient may have a constant chest pain or an intermittent chest pain. If the patient has constant chest pain, it may be without any significant hypertension or with significant hypertension. If it is without hypertension, it can be relieved with antacids or not relieved with antacids. If it is relieved with antacids, the diagnosis is either esophagitis or hiatal hernia. And if it is not relieved with antacids, the diagnosis is whether the patient has hemoptysis or no hemoptysis. With hemoptysis, it can be pulmonary embolism, and without hemoptysis, it depends on whether the patient has fever and purulent sputum. If the patient has fever with purulent sputum, it's likely to be pneumonia, and patient does not have fever and purulent sputum. It can again depend on whether it's aggravated or provoked by movement or not aggravated by movement. Aggravated movement may be pericarditis, not aggravated movement may be an acute myocardial infarction, panic disorder, or a hyperventilation syndrome. If the constant chest pain had significant hypertension, then it could be either MI, a dissecting aneurysm, or cochlear abuse. In patients with intermittent pain, precipitated or increased by breathing, it is more likely to be pleurisy, fracture ribs, costochondritis, or pneumothorax. And in not effective breathing and relieved by nitroglycerin, if lasting is less than 2 minutes, it is angina pectoris. If it is more than 2 minutes, it is acute pulmonary insufficiency. So this is the algorithm of the chest pain, which you have to how to assess the chest pain and how to reach a diagnosis. So, friends, the initial goal in emergency is to identify life threats. In all patients with chest pain, always examine the abdomen. And in all patients with pain abdomen, always examine the chest. Remember, airways, breathing, circulation always come first. Thank you for patient hearing, and I'm open to questions now.
Thank you, sir, for this wonderful discussion. I'm now requesting to all the participating doctors, please write down your questions in the chat box, or you can just click on the raise hand option on your screen to interact with Dr. Virmani. Please write down your questions at the chat box on your screen. You can also click on the raise hand option on your screen to interact with Dr. Virmani. Doctors, you can also just give your feedback on the chat box.
No questions from the chat box?
Waiting for some time if the doctors are coming with a question.
You can raise their hands, you can unmute them, ask them to unmute themselves or the video, and you can ask directly also.
Doctors, you can just click on raise hand option and then I can unmute the call.
Yeah.
If you want to ask any question.
One question from Dr. Nagaraja is here: how to differentiate between MI and ruptured esophagus? Well, as I said, the history is very important. The history of an MI presenting with hand on his chest, acute MI, non-hypertensive, the risk factors are there, is diabetes, smoker, overweight, etc. And ruptured esophagus usually occurs in patients who are alcoholic or abuse alcohol, and they have a sudden hematemesis. Hematemesis you will never see in MI, acute MI.
Okay, thank you for answering, sir. I'm just requesting to the doctors, if you want to interact, you can also click on the raise hand option. You can talk to Virmani.
His comment and experience, from the experience, what he has said, I would be glad to learn from the experience of others. If they have faced a difficult case, or you have faced any difficult case in your career, and you would like to talk about it, we'll be very glad to listen.
So there is a question from the Shaptoshi Moitro at the Q&A box. He wants to ask, how do you differentiate esophageal rupture and diaphragmatic rupture?
Esophageal rupture and
Diaphragmatic rupture.
diaphragmatic rupture. Okay, the esophageal rupture will have hematemesis. Diaphragmatic rupture will have sudden sagging of the whole the chest into the abdomen, and there will be severe pain at the lower ribs, at the lower edge of the ribs, and there may be herniation of the because of herniation of the gastric contents into the chest. Patient may have some breathlessness.
Thank you, sir, for answering the question. Dr. Katha Sagaram, do you want to say anything, sir? You are muted.
Hello.
Dr. Nagaraja Katha Sagaram, sir, do you want to say anything?
Yeah. Diagnosis. How we have to diagnose? Hello.
Yeah, go ahead, Dr. Nagaraj.
How to diagnose the ruptured diaphragm immediately?
Ruptured? Sorry, please come again.
You have told the ruptured esophagus and the ruptured diaphragm.
Yeah.
How we will diagnose ruptured diaphragm immediately?
By ultrasound and X-ray chest, you can see the gastric contents herniating into the chest. The ultrasound will also show that.
Thank you.
Thank you, Nagaraja. So I'm just requesting to all the doctors for the last time, if you want to ask any questions, please write in the chat box, or you can raise your hand by clicking on raise hand option. So we'll just wait for a few more seconds.
Yeah, no problem.
Okay, sir. Thank you, sir.